Is there something that I need to clarify more about what I said about treatment?
Why won't you treat me?
Yeah, so this is a very, very valid question. We know from many, many years of studying this condition, chronic lymphocytic leukemia, that unless the disease becomes manifest, in other words, unless you have symptoms, unless you have problems, then giving you treatment will not benefit you at all. So we defer treatment until symptoms arise. This is not the time, in other words, to give you treatment because you do not need it. It will not help you.
I don't understand. When people have leukemia, they get treatment.
Yeah. When people have a disease, they may get treatment, but what we will be doing to you is not telling you, okay, go home and do nothing. Quite the contrary, in fact. We will be monitoring you actively, so you will be visiting us. And in fact, during this first year or two, your visits will be rather frequent, every 3 to 4 months. And we will be, for you, for whatever issue you may want to ask for anything that bothers you. So this is a period that we call active monitoring, which is following you with physical examination, with blood tests, but also trying to respond to any issue that may arise. And there are some issues, we will discuss about it, but the knowledge that we have is that giving treatment at this stage with no symptoms, no problems whatsoever, will not do anything, will not have a beneficial effect.
Coming to the hospital every 3 months doesn't sound frequent. How does that help you figure out what's going on with me?
Yeah. So this condition is generally progressing slowly, and in some patients, not at all. So it's not something that evolves fast. It's not something that behaves aggressively, usually. Now, as I said, we will all be here for you, and you will get contact information about our team. I strongly recommend that you make notes about anything that worries you, and we will be there for you, here for you. So in case you need something before your next appointment, you will contact us and we'll try to, assess the situation with you, hear your problems, and if necessary, we will meet you again sooner than your next appointment.
Okay. Okay.
So is there anything else that you would like to ask at this moment?
So I just go back to work?
Yeah, you do. Yeah, and that's in fact what I was pointing to when I asked if there are other things that you would like to ask. So yes, you could go back to work. You can go back to work, and you can go back to your normal life. But there is one point that I would like to alert you about, and this is that people with your condition have an increased susceptibility to infections. So you may develop infections more frequently than other people without this condition. So in case you have fever or you have anything like cough, you'll have to notify us. You'll have to contact us.
Every time?
No, we'll give you instructions about that, but and we'll give you written instructions about that. You'll get a leaflet, and our nurse will explain exactly how to do it. But I would say that anytime you have fever, you need to carefully check for some things, like measure your blood pressure, see how often you have fever each day, and then, yes, please, you need to contact us. That does not mean that you will have to come to the hospital or be admitted, if that's what worries you. No, no way. But we have to be on the alert.
Okay.
Should we also discuss about other things, like what you should do in your everyday life besides work? I mean, in your everyday activities.
Okay.
So you should think of yourself as a person with a condition that is not preventing you from doing what you were doing before. Let me also explain one thing, and it's a critical thing. It's not your mistake. So you didn't do something that caused this condition. It's not known what causes this condition. It happened. But this may not prevent you from doing the things that you like, from enjoying doing any pastime that you like the most, from trying to lead a healthy life. I mean, I don't know what things you prefer doing in your spare time. You can continue doing them. So try to think that you are a person that can continue being active, though from now on we also have to be collaborating in order to, make sure that things will remain fine, and that if any problems arise, we will manage them early, and we have good ways of managing them.
Okay.
Anything else?
No.
So, Mrs. Warwick, I understand it's too much. So we said already quite a few things. A diagnosis with a rather scary term, leukemia. I also told you about infections. I gave you a schedule, so it's perhaps too much, which is why we need to develop together a strategy. Some things may work, others not, we will see, and we need to change them in the future. But I would repeat what I said about, making a kind of diary, but also taking notes of things that come to your mind, questions that you want to ask. And please contact us if you're particularly worried about something. We will have our next appointment so the first appointment will not be after 3 months, or 4 months, but I'd say in 2 months from now. If, however, something is particularly worrying you, please contact us.
Okay. All right. That's me being passive. I would like to say I could have cried, but I thought it would freak Kostas out.
The awkward thing was your passivity, because it's not.
It's really weird, isn't it? It's weird for me. Yeah. See, I could be an actress. Okay, so let's talk about the dynamic. I mean, I think you can all tell I was really freaked out, right? How well do you think Kostas did in trying to calm me down? Like, Was it working? No, it wasn't really working. Was that Kostas' fault? No, he was trying, right? And sometimes the patient is just where the patient is at, and they need some time to adjust and kind of pull themselves together for sure. So let's go back about, the things that Kostas said and how he said it. What kind of job do you think he did? We're totally judging you. Oh, we have lots of hands. Lots of people have opinions.
I'm going to number 2. There was something right at the beginning that I think was missed, and the diagnosis and the explanation was really good. As someone who's also taken a phone call from their father who said metastatic disease, I know exactly where that was going. He didn't. And so there was no kind of, what does that mean? There was the talk around, maybe not needing treatment and all that sort of stuff, but I don't think there was that calibration of, not that you would ever say it's a good thing or anything, but just someone hears that word leukemia, they're potentially switched off because they think I'm going to die. So that hadn't been recalibrated in that moment, which brings me to my next point of, you were by yourself.
Totally.
Where was the check-in that, would you like somebody with you? And yeah, sorry, Kostas.
Exactly, and that's what my point was going to be, because you're stunned. You're absolutely stunned. And the person sitting next to you, who you no doubt love, is going to be listening a little bit more, or at least someone you're going to hold their hand or whatever. But the fact that you were alone, I'm assuming Kostas and his nurse or whoever found out if you were with somebody, and apparently you came on your own, and that's why you're sitting there. Otherwise, of course, he would have had that partner come in to join you.
Okay. Usually the doctor doesn't have as much time and to explain what is CLL. That's a totally strange world. So you don't know, Lorna, what it is, although he says it's leukemia, but your world is broken already there. But if you have any questions, then Kostas should refer to a patient organization, because you don't have so much time. And if anything, you can call us. And it's really good to be short, but also concrete in a way. And we have made this same scenario in Denmark, also with the doctor-patient. And we made a leaflet with 10 questions, because you don't know which questions you have to ask the next time, and why, and how, and yeah. So you can be guided to have 10 questions, and maybe you have some more the next time again.
Yeah, but this comes at the next visit.
At the next visit, yeah.
Yeah.
So
Yeah.
this is disclosing a diagnosis.
Yeah.
So everything you say is very valid, but that would be after I have referred Lorna to a patient advocacy group, and
Yeah.
then she may get your help and then come more prepared in her next visit.
Yes, she will. Yeah.
Hello. I have to say, Lorna, you are a good actress. And yes.
No, because
just-
she was doing it too much. I mean, she was like falling apart.
Because we're also, I was trying to make sure
It
the
was
people in the back could see
excessive.
something.
It was very silent movie, 20s melodramatic.
Yeah. I have to say something very important. This is the big difference between the reality and the play. Because in my country, never a doctor will give the time you gave to Lorna today. Because they have more than 100 patients in the waiting room, yes, and the rate of waiting time is more than 7 hours.
I don't know if it's
I am a patient. I know that I traveled more than 1,400 kilometers to get my treatment.
I don't know if it's
Yeah,
any
in
consolation.
2002. And I remember when I was diagnosed, the only question in my head is, should I live? I will die? This is the first question. I didn't want to have some medical, information. I wish you asked the question about the guilt feeling in the beginning. It's not your fault in the beginning, because we need to know that it's not our fault in the beginning, and then maybe the medical, information and so on and so on. Because this is the most important things to know that. And another point is about you have cancer, you don't need treatment. And you have another one, you have cancer, the treatment is available, but it's not for you. This is the question of access come back to discussion, and also to reassure. I know that is CLL condition, but just to say what I want to say, because the same feeling I was like, I'm acting with Lorna. I was like with you in the play, and many scenarios in my head about many patients, CLL, CML, and so on and so on. This is the most important thing, to be reassured about our future, and why I don't know, I don't need a treatment. The question should be very explained to the patient, because I have cancer, but no need to have treatment. This is my concern, and thank you very much.
Follow what Bahija say. In my mind, there are a question, don't ask it. The question is, what will happen when the disease coming symptomatic? This is the question for the patient. This care for the patient is, okay, now I have no treatment. I agree. You say this, for me it's okay. But in my mind, the scenario is, what will happen when I am symptomatic?
Perfect. I am following you, both of you, very carefully. But I beg to disagree, because you need to take things at each patient's pace. So Lorna received the diagnosis of CLL. She also heard that she does not need treatment, and this is creating what Christina and psychologists refer to as cognitive dissonance. Two things that are both true, but clash. So you have cancer, and cancer, a diagnosis of cancer is associated with an immediate need for treatment. And in CLL, if it's asymptomatic, you do not need treatment. Both are true statements. Both are facts. Yet these facts create confusion. So to me, for a passive patient like Lorna, this is already too much to cope with. Bringing up the issue of treatments when the need arises would complicate things even further, which is why I emphasized, I repeatedly said, you can take notes about things that worry you. You may contact us at any time before your next appointment, because I'm sure that Lorna would go home, start thinking about it, start looking about it, and then read a lot of things that would be incomprehensible, difficult to grasp, which is why we need to give information at the right pace. I don't know, there are many colleagues in the room, and I would like your views. So, Tal?
I think that's you rightly said that every patient has got its own pace, really. For Lorna, it's all about just getting that information in the first instance that this is really unexpected, and essentially just even giving that comfort feeling that you're there to kind of support her during this discussion, because she needs time and space to go back and think about it and come back with some more questions. The issue I rightly pick up is that every place will have got different pressures, and patients sometimes will see, I want to get best information out as quickly as possible, but that is very, very difficult for us to give, and it needs to be tailored around individual patient need.
Isn't it also culturally, isn't it also context dependent? In other words, Bill, would that be exactly the same in Houston as in, for instance, Milano?
I think the general concepts of having this conversation with patients the same if you're in Houston or if you're in Milan. I think you hit on the nail on the head, and that is patients are very different. They have different perspectives, they have different needs, they're there to hear different things. The clinician needs to sort of have the skills and to understand that relatively quickly so that they can provide the information and the things that patients need when they see them. The patient population that I see is different than this conversation. Most of the patients already have a diagnosis when they come to my clinic. They've done some reading, and so the conversations I have are not to deliver the diagnosis, but a little bit more advanced in the path of the dialogue. So I think it's a matter of sort of understanding where the patient's coming from, what the patient's looking for, and what information they need.
So we both acknowledge that this is a very artificial,
Scenario.
this vignette was very artificial. I mean, I would have already met Lorna once in this context, which is different from what Bill just described. So it would not be the very first meeting that we have. But still, the purpose here was to try and present a few themes and then see how you reflect on those. There's a question from the floor.
Yeah.
Nora.
Thank you very much. Sorry. That was a very good role play, but I felt that the passiveness of the patient should not be taken as if she understood everything you were saying, but rather that she's so worried, she didn't know what to think anymore, and she's just overwhelmed by it.
Yep.
And she just couldn't do anything. But you, Kostas, was just talking. And you didn't give her questions that would get her to talk.
Which is very correct, appropriate remark.
And then at the end of the day, you also summarized for her. You didn't get a feedback from her. And that is essential to be sure that she really did listen to you and understood what you said.
You're my new doctor.
Thank you very much.
Nora's the second opinion. Andreas.
Yeah, thank you. So, great discussion, absolutely. There's one thing that I've missed, maybe not only in that discussion, but previously as well, that helped me with the whole why don't I get treatment option, and that is the explanation between treatment and cure. If my physician tells me this is your condition and there is no cure, right? So if I have a cold today, I'm not going to run to the pharmacy straight away and try and get medication to get rid of it because I don't have any, I can either handle the symptoms or I don't really have any symptoms. And I think that that's more to understand, said, okay, I have cancer, what's the cure, right? Is it an operation, is the chemo, is the what it is? But no, there is no cure for you. We'll monitor you, and if there is anything that's going to trouble you because it's getting worse or you have any symptoms, we can go and try and treat it. And, trying to break it down logically from that point for people and say, well, because they think immediately, treatment, I don't get treatment means they don't cure me, they don't want to cure me.
Yeah. Okay, we do need to move along, so we're going to go ahead to scenario number 2.
Lorna, before we do that, Christina, as the expert in the room on psychology, how would you summarize what you just heard?
Well, every point was valid. Maybe not all aspects, but I think all points were valid. What I wanted to say is that you validated the emotions in the beginning, but then left them completely out of the conversation. So you said, I understand this is a shock for you, it comes as a shock to you. This is the first time bad things happen. So that wasn't. Bad things happen, true. And then completely left emotions out of the conversation. So you might have asked, what do you think? If you need us, we'll be there. So that sort of insinuates support. But you could have asked, how are you feeling right now? I think that's the only thing I would have to comment on this amazing role play.
Thank you. So we're going to do number 2. Now, this is different because Jan is an experienced patient. So now they're discussing a treatment choice. All right.
Welcome, Mrs. Rynne. How are you doing today?
I'm good today.
So we are here to discuss the results of your tests and also decide about the next step, which is, as I see, treatment. So the disease is now active, meaning that we need to intervene. And considering everything, the results of the tests that we run, and also your other conditions, I would like to present to you the options that we have about your condition at this moment. So option A is to take pills, to take an oral medication, but you will need to take it every day until the disease progresses, until you fail to respond, in other words. Option B is to take treatment for around 15 months, and then we will be following you. And if sometime in the future the disease recurs, then we'll see what we do. So these are the 2 main options. Each of them comes with different challenges, but I think that we can manage them as they arise.
So if I take option A and take the continuous treatment, what might be the side effects?
Yeah, you can experience a range of things, from things like arrhythmias and blood pressure to bleeding. You may have bleeding in the skin, sometimes even more serious bleeding, but these are rare side effects. But you may also have things like pain in the joints. You may have diarrhea. So many different things, not always very, very bothersome, not always severe, but yeah, they are compromising your daily life. They could compromise your daily life, which is why we would need to be on the alert. Please bear in mind that these side effects wane with time. So they are most often appearing during the first phase of treatment, and then they wane off.
How long would that first phase of treatment last?
It depends. I cannot give you a definitive answer, so it depends.
So diarrhea and joint pain doesn't sound like something I want to do indefinitely. There's no certainty about that option for me.
No, there's not. But yeah, it comes with the treatment.
If I take option B, which is the 15-month treatment option, what does that look like? Is that going to impact my quality of life? Do I have to stop working?
It could at the beginning, because it's the mode of treatment is different, and we need you to come to the hospital often. So the first weeks will be quite challenging. Thereafter, things will be better, but for the first month or so, you will need to come to us frequently. So if that's a problem to you, yes, it comes with treatment B.
How will that impact my secondary immunodeficiency issues?
That we can't tell. I mean, in general, if leukemia is controlled, if CLL is controlled, then immune status is also improved. But the option B includes the administration of an antibody, and that antibody may cause some issues, may cause some problems that we need to be aware of.
Will I need to stay in hospital during the treatment for option B?
No. You will need to come to the hospital frequently at the beginning, but not stay at the hospital.
Surely increased visits to the hospital exposes me to more immune challenges.
Yes, indeed, but as I said, we cannot do anything about it.
So it sounds like it's a rock and a hard place decision.
It is.
If I take option A and stay on the continuous treatment and tolerate the side effects, how long might I get in that phase before I have to look at another treatment?
Yeah. In your patients with your profile may respond quite well for 6 to 7 years. So we think that you may we may achieve good control of the disease for at least 6 or 7 years. But I need to emphasize, every patient may respond in a different way.
So as a person who's younger for CLL, I need to know that I have some longevity. If I choose the continuous treatment option, and I fail it or become intolerant to it, then what would be the next option for me?
Yeah, it's good that there are options today. So studies and our experience tells us that once, if this treatment fails, then we still have options that may achieve control of the disease, and progress in research on CLL gives us new options, new drugs. So it doesn't mean that if this treatment fails, we have nothing to do.
So if I have other comorbidities and I'm managing some other health issues, how will the option A, continuous treatment, affect that? Is there contraindications with medications, for instance?
Yeah, there are, but we'll see when and if it arises.
If I take option B and pursue the fixed duration treatment, can you tell me how long I might have off treatment after that 15-month phase?
I'm presenting both options because I think that they're more or less equivalent. So I would give you the same time for option B as well.
So you're my doctor, and I can't make the decision. You have to help me now.
Yeah, but it's really in the end up to you, Ms. Rynne, because it's, do you want to come to the hospital frequently at the beginning? Do you want to take drugs every day? So this is a decision that you have to make.
And I guess I'm in a really privileged position because I'm being offered these two options, and that's not necessarily the case for most patients.
That is very true.
Yeah.
So would you want to think about and come back again and tell me what you have decided?
For sure, I'm going to talk to my local support patient advocacy group. and have a think about it.
Okay. All right. Yeah, hands. I like that we don't even have to ask. Does anybody have anything to say? Because right away we see all these hands go up, but yeah.
I think that was a difficult one, no doubt about it. You had an informed patient, but by the same token, I thought the options you gave and the way you articulated those options, even for an informed patient, made their position difficult in terms of some of the answers. I think from an informed patient's point of view, they would like the clinician to give them the clinical opinion as to what clinically is the best thing for them. And then, in terms of the shared decision making, depending on their lifestyle and other issues that are going on, to be able to make it. I felt you gave Jan a very difficult decision to make because the guidance was very much down to Jan. Jan asked questions about how and when, and some of the answers were vague. So
Okay,
therefore it
so
made...
I was waiting to hear this word. So I was vague and elusive.
Were you purposely being vague?
Yeah.
Yes.
That
Yeah,
was
yeah.
his directive in the
Yeah,
scenario
okay,
too.
right.
Following the
Yeah,
So we are glad that it went through. So I was elusive all the time.
Yeah.
And that is very true.
I just was hoping that you would mention as one of her treatment options, exploring clinical trials, even just to say, here's the full landscape of your options.
Patty?
Hi, I would like to, if you don't mind, revisit Lorna. Lorna is going to be in that stunned condition for a very long time. And she needs a caregiver. I don't fault Kostas for this, but I do think up front of having a reassurance that Lorna didn't cause this, and that Kostas, you are confident in saying that she will be okay without treatment for a long time. If you can express that confidence, that would be a very good thing for her, I think. And the importance of a caregiver just can't be underestimated. I interviewed a doctor a number of years ago who said, when I see a patient walking down the hall towards me for a clinical trial or for some bad news and they don't have a caregiver, I worry that in 9 months to a year, they're going to fall off treatment or they're going to lose hope or they're going to experience some kind of a setback that a caregiver could really help, because the caregiver will say, I remember all of the things that we looked at that we could have done, all of the choices that we might have had, the advice from your doctor. I remember why we had confidence in this. I remember why we had confidence in this doctor. But if that person isn't there at the time of crisis to say, it's really important that the caregiver is there at that time of crisis to say, I remember all of those things that we decided. I remember that we had confidence in Kostas. I remember, but you forget. Let me remember for you, stay on treatment or stay the path or whatever.
It's good, Patty. We are running over time, but I just want to recap a couple of things. With our global patient survey, when we asked patients with CLL about shared decision-making and how a doctor encourages it or not, empathy is not the issue. You know, the majority of patients really feel like their doctor is empathetic about their situation and realizes the weight of what they're going through. The issue comes down to those conversation styles. Are you letting them ask questions? Do you have time to do that or not? Do you have the time then to check when you give an answer that the patient actually understood what you said? And if you don't have the time to do that, are you helping them figure out where to go to get that information so that they're more equipped the next time to participate more fully in a conversation? And we realize there's lots of time limitations in clinics, but do you know of other, if it's within the hospital or community resources like patient organizations, what do you do with that gap? Because we know what happens. It's called Dr. Google. And, to be honest, most of patients do say they end up in patient organization websites, and they feel like they're getting good information that way. But if you're not helping them get there, then it's left to the patient to find that path. And there's a lot of distractions along the way. And we think it's getting a little bit more awkward with AI and what ChatGPT and things like that are actually going to say to a patient to help fill some of those gaps. But yeah, to be clear, we did tell Kostas the second time to be kind of abrupt and not empathetic. So I know that there can be some criticisms of that.
But on that, same thing, we have acknowledged that patient empowerment means two things, two pillars. The first pillar is information and support to the patients, but the second pillar that is equally important and critical is support to the physicians in improving their communication skills.
Yeah.
So Eric has a broad program that is coordinated by Christina. Christina, I shouldn't be talking for you. So if you can please tell us what you have already developed and is on the dedicated website about that. So for a physician like me, who is elusive, or who is really feeling awkward because Lorna is very silent and very passive, there are ways. Christina?
Well, it all started with some interviews we did with patients in Greece, and we realized that there are a lot of problems. For example, when a patient is very passive and there are silences, the other person instinctively tries to fill in the gap of silence.
Which is what Nora said.
Yeah, exactly. So this became an Eric project just because we found so many problems with our doctors in Greece. So we decided to do a CLL patient empowerment program that indeed has two pillars. It's a big website that's got information for patients, but also which is meant to be given out by doctors as well. But also we did information for doctors that is given in many forms. There are podcasts, there are leaflets, but also there are role plays that, of course, are in the form that Lorna and Jan already did with Kostas here. And we think that is quite helpful. Also, during every ERIC meeting, we have a specific session. We've got a dedicated session just for patient empowerment, and we did scrap that. We did three workshops during the ERIC meeting, and we had Nick York there with us. And it was full of physicians and patient advocates and patients. So it was quite a success, I might say. That's all from me.
Very quickly.
I'll try to be short. I'm Dr. Raswell, and this is all for us. I'm a member of committee of AHA. Let my friends support me and Natasha. We can organize some tutorial for doctors, patient-doctor communication enhancement. And
it's already happening because I'm also serving in various EHA committees, and we decided a few years back that we need it, which is why EHA has appointed Christina the responsibility of organizing, in the context of the annual meeting, a 2-hour workshop. We will have the 5th version next year that addresses a particular aspect of patient-physician communication.
It will be nice. I participated in 2005. It organized by ASH, but it was last one.
Yeah, and thanks for raising that, because I just want to stress that ESMO published a guideline on communication, doctor-patient communication, without any insight from patients.
I know.
That's not acceptable. So we should ban that guideline, really.
Okay, we are way over, and the break is ready, so